Um, Now we'll talk about the spondyloarthritis aspect here, and Dr. Walid Hafid will enlighten us about this topic. Thanks a lot.
Thank you, Mr. Chairman, for this kind and warm introduction. I also would like to congratulate Dr. Al-Hamoud for this focused and smooth talk, and I would like to congratulate the Saudi Society of Rheumatology for this excellent conference, and also thank colleagues in AbbVie for inviting me to this satellite symposium as part of the SPADE Advanced Educational Program in rheumatology. So without further ado, I'll be switching gears from like the clinical rheumatology into a step backward, and we will talk a little bit about the translation of the bench side knowledge that we learn into the clinical practice in the clinics. And I'll be shedding more light on the pathogenesis of the spondyloarthropathies. Okay, so these are the outlines that I'll be covering over the next 15 minutes. And here are my disclosures, and let's start with this slide. So all we know that spondyloarthropathies is it's a group of a family of diseases that affect either axial or peripheral joints, and from which we have like the different diseases that you can see here in the screen. Now, spondyloarthropathy is a disease that is not only confined to the skeleton. It involves every single organ, starting from the head all the way to the toes, and you can see here that it involves skin, eyes, gut, as well as the nails. Now, to assess the severity of the clinical involvement of the organs in patients with spondyloarthropathies, over the past several decades, there have been several disease assessment or outcome measures that have been proposed in the clinical practice. I'll be shedding light on two of them in the field of psoriatic arthritis, and one that assesses the disease activity of ankylosing or axial spondyloarthritis. We all are aware of these two disease outcome measures. The first one is the DAPSA, and the other one is the MDA. And I'll be shedding more light. So as you can see here, that DAPSA is a disease outcome measure that is composed of 5 different domains, starting from the tender points towards the tender joints, swollen joints count, and then an outcome or a domain that is usually responded by our patients, patient global visual analog score, and pain score, as well as the CRP level. Now, the challenging or the drawback of this outcome measure is that it misses the skin domain, and it also does not provide any insight on the enthesial involvement. The good thing about this outcome measure is that it is easy to perform in a busy clinic. It does not require much of the calculation. It's just like a sum of all these items, and the higher the score reflects the worse the disease. Now, the other disease activity measure is the minimal disease activity score, which luckily covers the items that are not covered in the DAPSA, namely the skin that is reflected by PASI, and of course the enthesitis that is also taken into account with the counting of the tender enthesial points. Now, these are like the two psoriatic arthritis disease activity measures. They are simple. They are available on the internet. We can print them and we can apply them easily in our clinics. Moving on to the axial spondyloarthropathy, we're all aware of the ASAS outcome measure, which again involves 4 different domains or items. So it starts with the function that is calculated with the BASFI, moving on to the morning stiffness, patient global assessment, which is scored from a point from 0 to 10, and again the total back pain, again that is scored from 0 where is no pain all the way to 10 where is significant amount of pain. And the ASAS response criteria, measures like response to the treatment, and like the standard or the average is considered like ASAS 40. And most of the literature and the studies consider this ASAS 40 as a primary outcome or endpoint in the randomized controlled trials when assessing for the therapeutic effects. Now, what we have learned over the past decades from applying these disease outcome measures, that there is still unmet need for treatment of the spondyloarthropathies. And as you can see here, that we have significant molecular targets when it comes to psoriatic arthritis. However, moving on to ankylosing spondylitis or axial spondyloarthropathy, we don't have like specific molecular targets that can be targeted exclusively for this disease. And you can see in the square that at least like 1/3 of patients with spondyloarthritis do not respond to the current therapeutic options and fail to achieve treatment targets, which really leaves us in a huge challenge of and thirst of trying to find new molecular targets in the management of these patients. Now, as you can see here in this slide, here we have a study that tested 80 patients, and they found that approximately only 25% of patients they achieve very low disease activity at once, from which only 17 they sustain that remission over like 1 year period. When DAPSA was applied to these patients, it was found that only 35 patients they achieve remission at least once throughout like the year period, and only 30% of them they sustained the remission over this year. So again, the numbers are telling us that we still have unmet needs in the management of significant amount of patients that ranges somewhere between 70 to 75% of patients. Now, I'll skip this slide. It only shows us that the musculoskeletal symptoms remain like the top of the list when it comes to patient experiences with regards to their medications and responses. Now, again, if you look at the axial spondyloarthropathy, again, you can see that up to 40% of patients fail to respond to the initial TNF therapy, requiring switching to another anti-cytokine treatment modalities that we have. And half of these patients, sometimes they go into the 40, ASAS 40 response. However, down the road, they can also lose that response. And this is universal across all the TNF-alpha treatment like family. Okay, moving on to the interleukin 17 inhibitors. Again, as you can see here, that up to 40% of patients who fail initially they fail the anti-TNF. Again, they experience the same failure experience with the anti-IL-17 inhibitors, and only 40% of them achieve like more stringent ASAS 40 response. So putting all of that together, we can see that we still have several other domains in the spondyloarthropathy disease that are not yet fully or adequately targeted with the available medications that we have. Is this because of the poor understanding of the pathophysiology of the other organs that are involved? That's number one. Number two, are we not able to target like more than one molecule with the available anti-cytokine therapy? Are there several molecules or chemokines that are actually implicated in the pathogenesis of the disease? So I'll skip. This is more of like a clinical. So what are the key inflammatory cytokines that are involved in the musculoskeletal and dermal changes? What happens, as we all know, that the initial trigger of the cytokine secretion or response is when the T cells, combine with the dendritic cells. This leads to the first, secretion of the cytokine pool, mainly the, the interleukin 12 and the TGF beta, as well as interleukin 23. Now these cytokines in turn actually activate the T helper 1 cells as well as the T helper 17 cells, which in turn release the second pool of the cytokines, which include the TNF alpha as well as the interleukin 17 and some other cytokines such as the interleukin 6 and interleukin 1. Now, what do all these cytokines do? They show us I think I'm hearing some noise somewhere in the back, so if you can kindly concentrate here. All these cytokines that are produced, they in turn start showing the clinical manifestations in form of decrease in the osteoblastic activity, increase in the osteoclastic activity, increase in the chondrocyte formation, as well as more and more injury to the epithelial cells and production of the keratinocytes. Now, all of these changes are reflected clinically in form of cartilage destruction, bone erosion, as well as the tendonitis, enthesitis, osteitis, and so on, as well as skin and nail psoriasis, and also the involvement of the gastrointestinal tract and the sacroiliac joint. As we all know that these changes are not confined to the musculoskeletal system. These changes also go beyond that, and they can affect both the gastrointestinal tract as well as the eyes, causing IBD and also causing uveitis. Okay, so how do these cytokines perform their pathogenetic mechanism or action? They do that with the help of the cytokine signaling intracellular pathways. There are several cytokine signaling intracellular pathways. The most common is the JAK-STAT signaling pathway. So basically, what does the JAK-STAT signaling pathway does when it is activated? It actually leads to the downstreaming of the cytokines as well as the growth factors, which is the key role in the which plays actually the key role in the inflammation and thus autoimmunity. So if we inhibit this JAK-STAT signaling pathway, will we be able to better achieve remission in these diseases, which can again be reflected on the disease outcome measures? Let's look into that. So this is a hot topic, and it's usually presented in the board exams. So my fellow colleagues, they might want to bear some attention. So how does the JAK-STAT signaling pathway work? It works through 5 stages. So the first step is when a certain cytokine binds into the receptor and allows transphosphorylation and activation of the JAKs that are actually available intracellularly and are attached to the receptor. Step 2 is the activation then of the JAKs and the phosphorylation, and then the receptor tail. And then what happens is that STAT proteins dock on the phosphorylated receptor tails and are phosphorylated by the activated JAKs. So here we have the JAK-STAT binding when it's step 3, and then in step 4 the phosphorylated STATs dissociate from the receptor and then they dimerize, and in step 5 they migrate into the nucleus and then activates gene transcription and then further and further cytokine production, release, as well as the inflammatory response then begins. So this is the slide that can help us better revise or understand the JAK-STAT signaling pathway mechanism. So what happens? What are the key cytokines that can bind into this receptor? So look at this. We have interleukin 7, interleukin 15. We have 21. Those we still don't have any molecular targets for them. However, look at this. We have interleukin 12, 23. We have the stimulating factor. We have the interleukin 10. We have the TNF alpha. So JAK STAT signaling pathway plays an important role in attracting these cytokines into the cell and then starting, the production of more and more of the inflammatory response. So some of these cytokines, they bind directly to the JAK-STAT signaling pathway receptor, and some bind indirectly, as you can see here in this slide. Now, what happens if we start, blocking these, cytokines from binding into the JAK-STAT, receptor? So let's see that in this. So this is what happens in the pathogenetic, phase, where all these cytokines help, activation of the T1 helper and T17 helper cells, which in turn, releases more and more cytokines that can sustain the immune response, and then the clinical picture that is compatible with the spondyloarthropathies. Now, if we block these JAK-STAT signaling pathway mechanism, so we're actually blocking all these cytokines, either the ones that are bind directly or the ones that bind indirectly, from doing their pathogenetic mechanism, which is the activation of T1 helper and T17 helper cells, and this leads to the cessation of the inflammation and the drawback of the cytokines from the circulation. That means in turn we are stopping the inflammatory response and decreasing the autoimmunity. So ladies and gentlemen, with this I come to the conclusion of my talk. Before I finish, I have only one poll that again you can screen the QR code and start choosing like your responses. The question is, how well do you understand the direct and indirect effects of JAK signaling pathways in the pathogenesis of the spondyloarthritis? So far we have 6 respondents. Now there are 10. Few more seconds. I guess this is reassuring. Thank you so much.